I'm Dr. Sushila, professor in the Department of OPG. So, in 3-4 classes, we learnt about cesarean section, definition, types, steps, then difficulties, complications, on table, immediate post-op, remote and late and remote complication of cesarean section. Then all the measures to reduce the incidence of cesarean section also we learned. Now we'll go to vaginal birth after cesarean section. Okay. So old dictum was one cesarean, always cesarean. Now it has changed. One cesarean, it is always a institutional delivery. No female with cesarean section should have home deliveries or delivering on the way to hospital, and such things should not happen. All pregnant mothers with cesarean should deliver in a institute where there are facilities for emergency section, blood and blood products, pediatrician is there and obstetrician is there 24/7. Now we'll go to what happens to the pregnant lady in future pregnancy. As I told you, one cesarean doesn't mean that it is always cesarean. She can have vaginal birth. Okay. Success rate is known to be around 60 to 80% success rate is there. Okay. With few bit of morbidities like heavy bleeding, admission to ICU and all. Other than that, success rate is around 60 to 80%. Okay. So it depends on proper selection of the mother for normal labor, then availability of a senior obstetrician, and then availability of pediatrician, blood products, electronic monitoring for the fetus and all those things. Now we'll see how to select a lady for cesarean section. Okay, because we know one of the complication of vaginal birth after C-section is your uterine rupture. Okay, so being an obstetrician, we should try to avoid occurrence of uterine rupture, or at least recognize the early signs of uterine rupture and manage it properly so that mortality is avoided and we can reduce the morbidity to both mother and the fetus. Okay. So risk is, as I said, it is mainly rupture. Okay. So now going to rupture of the scar and dehiscence. Okay. There are two terms here. One is rupture of the scar, other one is dehiscence. Rupture means all three layers of uterus have given way. That is endometrial, myometrial and serosal layer, they are open. So once that happens, membrane ruptures and fetus is seen in the peritoneum, there is heavy bleeding. Okay. So there is other term called dehiscence. Dehiscence means endometrial layer, myometrium has given way, but serosa is intact. Here membrane is not ruptured, fetus is in utero, there is not much bleeding into the peritoneal cavity. So outcome is better with the dehiscence compared to rupture of the uterus. So early recognition of all this is a must. Okay. So we will ask you what is the difference between rupture and dehiscence. Okay. Now coming to risk factors for rupture of a scar. So in LSCS, as I already told you, in LSC lower segment cesarean section, it is somewhere between 0.2 to 1.5% chances of rupture. In classical, it is very high. It is between 5 to 9%. Same thing with the T-shaped incisions and hysterotomy scars. Okay. So a lady who had scar rupture in the previous pregnancy. She has very high risk of rupture in the present pregnancy. Like in LSCS, it is around 6% increase in the 6% chances of having recurrent rupture. In classical, it goes up to 32%. Okay, that's why a female with previous scar rupture, better to take her for repeat cesarean. Okay, so how to select a lady for vaginal birth? For that, we should go in detail. We'll start with history, that is past obstetric history. One is number of scars. Okay, so that means number of cesareans she had in the past. Okay, so a mother who has only one cesarean is only one, not one or more, it is only one cesarean in the past, is eligible for VBAC. Okay, if she had two, she is for cesarean, 3 cesarean, 4 like that. Okay, so number of previous sections, it is only one previous scars. Okay, 2 means she is for elective cesarean. Then we'll go to indications for cesarean section. This is to know whether the condition is a recurring condition or a non-recurring condition. Like, as I told you, if it was done for scar days and scar rupture, so it becomes 6% to 32%. So, if it is done for scar rupture dehiscence, it is a recurring condition, so she is not for VBAC. If it is done for obstructed labor, she is for cesarean. If it is done for failure to progress or cephalopelvic disproportion, so she is for repeat cesarean section. In CPD means cephalopelvic disproportion, that is bony pelvis is not adequate for delivery of the fetus. So if that is the case previously, so now it is going to repeat, because we know second child is going to be bigger than the first child, third is going to be bigger than the second, fourth is going to be bigger than the third, but after 4 weight goes on reducing. So if it is done for recurring conditions like rupture uterus, obstructed labor, CPD, failure to progress, such cases always terminate by C-section, they are not for VBAC. If it is done for non-recurring condition, all of you know few conditions like abnormal presentation. Previously, if it is done for breech presentation, primary with breech, we do cesarean. Now it is cephalic, yes, she can be allowed for vaginal delivery. Previously oblique lie, now it is cephalic, she can be allowed. Previously it is done for fetal distress, now there is no fetal distress, CTG is normal, she can be allowed. Okay, post-datism if it done, now it is normal, she can be. Previous twin pregnancy, now it is singleton, yes, she can be like that. So we have to know the indication for previous cesarean, okay, whether it is a recurring condition or non-recurring condition. If cesarean done for non-recurring conditions, yes, she can be selected for VBAC. If it is for recurring conditions, she is for elective cesarean, don't allow her for vaginal birth. Okay. Then, so after indications, then per-op complications. On table, if there were any complications. So if at all there is any, usually we mention it in the discharge summary, like per-op there were dense adhesion or extension of the margins and all those things, blood loss, amount of blood loss, placenta, all those things we mention it. Any dehiscence was there, rupture was there, everything we mention it. So if she has the record, yes, you can go through it. Otherwise, indirectly you can ask her what was the duration of surgery. If she knows that duration of surgery was lengthy, 2 hours, 3 hours, they had some problem, they took lot of time for cesarean, that means there was some problem on OT table. Okay, such cases don't allow for VBAC. Usually that will be a case of lateral extension of the margins, that causes heavy bleeding, okay, and lot of tissue handling, and approximation may not be good, okay, and too many people handling the tissues, okay, that can lead to lot of bleeding, and in future adhesions, and scar is weak and chances of giving way is very high, okay. Then if they have found out some uterine anomaly, sometimes undiagnosed uterine anomalies we see, like unicornuate uterus, bicornuate uterus, or with a rudimentary horn, uterus died albeit septum is there, such cases, or there is a fibroid in the lower segment, upper segment, wherever it is, if you have mentioned, yes, okay. If such condition is there, don't allow her for vaginal birth and take her for repeat cesarean section. Then following delivery, any complications, like she was hospitalized for a longer duration, that means she had some problem in the post-op period, okay. Then infection, so there will be pus discharge through the suture site, fever, chills, hospitalization, repeated dressings, is it not, blood transfusions, resuturing, all this indicates infection. And wound healing will be by secondary intention, because of fibrosis, scar is less healthy and strength is less, it will give way. Such cases they are for repeat cesarean section. Then comes interval between two pregnancies, okay. So if the interval between two deliveries, that is following one cesarean, if it is less than 18 months, scar is found to be weak and better to terminate by C-section. If it is more than 18 months, she can be allowed for vaginal delivery. Okay. Then history of having normal vaginal delivery, that is also very important. Like first one was the cesarean section, second one normal delivery, baby is alive, third one, yes, she is for vaginal delivery. Or first one was normal delivery, baby alive, second one is cesarean, for third if she comes, because she had a successful vaginal delivery, she can be allowed for vaginal delivery this time, okay. So we say Vbac, that is vaginal birth after cesarean is successful if delivery occurs through vaginal route, both mother and the newborn is alive. Otherwise, we say it as failed Vbac. Like vaginal birth, baby died, that is not successful. If mother dies, no. Or she has rupture during the course and laparotomy done, that is failed Vbac. So successful Vbac means it is terminated by vaginal route, baby is alive, mother is also alive, okay. Yes. So all this history, past obstetric history, you should confirm, okay. That is number of C-sections in the past, okay. If she had vaginal delivery, 1 or 2 vaginal delivery, it's always good. It should be only one scar, not more than one. Previous vaginal deliveries, indications, whether it is recurring condition or non-recurring condition, then any problem, post-op problem, and interval between the pregnancies. Next we will go to present pregnancy. So present pregnancy, so we have to go, again we have to take history regarding the mother, any medical conditions she has where she cannot be allowed for vaginal delivery. Like she is elderly, like more than 30, 35. Obesity, yes, it's difficult, okay. She is hypertensive, GDM is there. Such cases, better to terminate by C-section, okay. Any medical condition with a scar, she is for cesarean section. Then coming to fetus as such, weight of the fetus, okay, clinical assessment as well as by ultrasound. A average size baby is the ideal case for Vbac. Like from my experience, anything less than 3 kgs Vbac will be successful. more than 3 kgs is difficult. Okay, average size baby, that is less than 3 kgs. Okay, and it is always a singleton pregnancy, vertex presentation, no abnormal presentations, like it is not a breech, it is not occipito-posterior, not oblique line, nothing. Okay, it has to be by cephalic presentation and presenting part should be a vertex, then only we have to take. Okay, understood now? That means previous cesarean is there, now it is occipito-posterior, no, she is for C-section. Previous scar, breech presentation, no ECV, nothing, she is for elective cesarean. Okay, or she has twins now with a scar, she is for C-section. Okay, anything other than vertex presentation, she is for C-section. Okay, then coming to liquor. Okay, excessive liquor with previous section, she cannot be allowed for vaginal delivery, she is for C-section. Oligohydramnios, yes. IUGR is there, okay, for C-section. Big baby, C-section. Okay, then coming to gestational age. What is her gestational age? That is, she is near term, that is 38 to 40 weeks only. If she is in labor by 33 weeks, she is for C-section. 34, 35 also. Term is 38 to 40 weeks. If she is post-dated, so she has crossed expected date of delivery, not gone in for labor pain, she is for C-section. Okay? Right? Then comes, this is we assess by clinically, we assess, and by ultrasound, oligohydramnios, polyhydramnios, and we can confirm the weight by ultrasound and all those things. Next comes, we can few points in ultrasound to assess the strength of the scar. Okay, that is also we are doing it. That is, to assess the strength of the previous scar, we measure the thickness of the scar by ultrasound near term. So anything more than 4 mm, scar is supposed to be healthy. Less than 4 mm, it is weak, chances of giving way is high. Okay, that is one thing. Other one is, they measure the myometrial thickness along the scar line. Okay, if it is thinner, that is less than 3.5 mm, that means scar is supposed to be weak. Or if they are finding some crater of about 5 mm along the scar line, that means scar is weak. Okay, that one we assess by ultrasound. So we have to rule out all these things from taking history and clinical examination, then confirm it by ultrasound. Okay, now we have selected a lady with only one scar, single fetus, then cephalic presentation with vertex presentation, adequate liquor, then placenta is normal, there is no placenta previa, that is also important. Then interval between two pregnancy is more than 18 months, she has no medical contraindications, baby is fine, CTG is normal, everything. Now she is the lady for Vbac. Before allowing her for vaginal birth, again we have to assess cephalopelvic disproportion for this delivery. Okay, so how to assess the cephalopelvic disproportion? That method is Monro-Kerr-Muller's method. Previously I have taught you. So by Monro-Kerr-Muller's method, by manual examination, we have to rule out cephalopelvic disproportion. So once we have ruled out all these things, so we get a lady for vaginal birth after cesarean. Okay, clear? So take history, she should have only one scar, not more than one, single fetus, vertex presentation, average size baby, liquor adequate, she is near term, she has no medical conditions. Okay, then clinically we have assessed the pelvis is adequate, scar strength by ultrasound it is more than 4 mm, then we can select her for vaginal birth after cesarean section. Okay, so clinically also we have assessed the pelvis. Now we have allowed her for vaginal delivery. If she goes in for spontaneous onset of labor, she is the ideal candidate and success rate becomes very high if she goes in for spontaneous onset of labor. Yes, otherwise also. So once CPD is ruled out, you can induce the labor. Okay, induction of labor is not a contraindication with previous cesarean section. Okay, but with previous scar, you should not attempt for external cephalic version at all. You should not do it because she has a scar. Okay, so induction of labor, if Bishop score is more than 6, yes, we can augment the labor with oxytocin. Otherwise, we can prime the cervix with PGE2 gel, dinoprost gel, that is cytotec gel, all of you have seen it. Okay, so we can prime the cervix and usually we don't use PGE1 tablet, that is misoprostol tablets and all. Usually with a scar we don't use it because studies have shown that they cause, even by practical experience, we know it's going to cause meconium strained liquor and chances of rupture of the uterus is slightly more with PGE1 tablet. So ideal thing is for priming the cervix, PGE2 gel is ideal. Okay. Okay, so you have primed the cervix, she is in labor. Then how do you manage her? That means in what way it is different from normal labor. Now she has gone in for labor. Now we'll see how to manage this lady with a cesarean scar. Okay. Now before this we have to take consent for Vbac. She should be agreeing for this. Okay, that is very very important and she should know the complication of Vbac. Okay, and better to take consent for peripartum hysterectomy also. That should not happen actually, but if at all anything goes wrong, she should be agreeing for peripartum hysterectomy. Okay, so everything then she has given consent. Yes, now she is in first stage of labor. Here in normal labor we ambulate her. In Vbac better not to ambulate. Okay, because it may lead to rupture of the membrane and cord prolapse. Okay, so ideal is give her left lateral position. Okay, then you can augment the labor with oxytocin. Just like normal labor, we can use 5 units of oxytocin, but under monitoring. Okay, and practically what we do is we use less dose of oxytocin, like instead of 5 we use 2.5 with a scar to be on safer side. Otherwise 5 is also okay, but it should be under continuous monitoring. Okay, and you can give her a sedative, like usually we give tramadol, that also you can give. Okay, then continuous maternal monitoring is by pulse, BP, look for any hematuria, urine output, all those things. Okay, then coming to fetal monitoring, it is always continuous fetal heart rate monitoring. Okay, that is we have CTG, so delivery should be under continuous CTG monitoring. Okay, so if everything is fine, and we can continue oxytocin under continuous monitoring. Now coming to second stage, this is first stage, nothing has happened, everything is going on well. Then second stage, that is when cervix is fully dilated. Yes, now you can put her in supine and encourage her to bear down. Okay, she can bear down in second stage. And if head comes out, yes, give liberal episiotomy and deliver out. Otherwise, if it is getting prolonged, okay, better to terminate second stage using a outlet forceps or a vacuum. Okay, I prefer to use vacuum because it causes less maternal injury. Okay, either outlet forceps or vacuum use and cut short the second stage of labor because prolonged second stage stretches the lower uterine segment and can cause rupture of the scar. Okay, now coming to third stage, usually there won't be any problem. So once baby is handed over to pediatrician, wait for some time for the placenta to get separate from the wall and get expelled. Usually that happens. Okay. Then once placenta is out, just examine it and see whether it is complete or not. If it is incomplete, that means one or two cotyledons are inside it and it may lead to PPH. Okay. Then observe her for 2 hours, then shift her to wards, just like in any other thing. So only difference is first stage, no ambulation. Okay, we can prime the service, we can augment the labor, but it should be continuous CTG monitoring and maternal monitoring. Second stage, cut short with a outlet forceps or a vacuum and give liberal episiotomy. Third stage also, it goes on well. Okay. Okay, so this everything has happened well. Everybody is happy. In the meantime, during labor, if anything untoward happens, okay. So all of you know signs and symptoms of scar rupture. So during monitoring, okay, earliest sign of scar rupture is unexplained maternal tachycardia. Our pulse rate was somewhere around 84, 85, 86, 90. All of a sudden, it goes to 112, 113, 120, 126. That means scar has given way. So first thing to do is stop oxytocin. Just stop oxytocin, shifter to OT. So earliest sign of scar rupture is maternal tachycardia. Okay. Next comes your pallor and all those things, hematuria, all those things come later. Earliest will be maternal tachycardia. In the fetus, she is on continuous CTG monitoring. Any persistent late deceleration and variable deceleration, okay, indicates rupture. Stop oxytocin, shift her to OT. Okay, these are all the signs of early rupture. Late comes low BP, air hunger, pallor and all those things, and fetus bradycardia and fetal demise can occur. Okay, that should not happen. So we have to recognize rupture at the earliest stage, stop oxytocin and do laparotomy. Okay. Okay. Then in the meantime, if there is no progress, we are augmenting the labor. Okay. And after 4 hours, you do one PV, cervix is not giving way, presenting part is not descending down. Yes, you should not wait too much. Yes, in the meantime, shift her to OT and terminate by C-section, any undue prolongation. Okay. So cervix dilatation is not occurring like normal labor. That is 1 centimeter per hour. It's not happening. Yes. Okay. 4 hours you wait, then take her for section. Or thick meconium stained liquor is there. We take them for C-section. If it is clear liquor, yes, we can be. And any CTG variability, she is for C-section. In third stage, usually placenta will get separated on its own if at all there is any delay in expulsion of placenta. Okay. Then manual removal of placenta and all, we should not be done in labor room. Better shift her to OT and do manual removal or explore whatever. Usually by ultrasound we will have ruled out placental morbid adhesions. Okay, that also I am going to tell. Okay. Okay. Now coming to, suppose lady is with one scar and placenta previa. Okay. She is not for Vbac, she is for C-section only. Okay. Then timing of elective repeat section. If she is for vaginal delivery, yes. Now when to take her for elective season. Suppose she has a scar done for recurring condition, she is for elective cesarean. That means we don't allow her to go into labor. Okay, we do a elective cesarean. When to do it? Okay, so ideal is during term, that is 38 to 40 weeks. That means usually we can take her for elective cesarean 1 week or at the most 2 weeks before EDD, not before that. Baby will be premature. Okay, maybe at 38 weeks or 39 weeks, we would like to take her for C-section and terminate her pregnancy. Okay, now we'll go to peripartum hysterectomy. Okay, peripartum hysterectomy is removal of uterus immediately after delivery, maybe following normal delivery or C-section. So indications are badly ruptured uterus or severe atonic PPH which is not responding to medical line of treatment and such conditions. So indications are okay. So usually if it is a clean scar, yes, we can suture it up. Suppose it is irregular margins extended laterally to the broad ligament and all, better to do peripartum hysterectomy. Okay, or she goes in for atonic PPH. Okay, and we do all medical line of treatment. We give oxytocin, ergometrin, prostaglandin, all those things. If not controlled, then we can do peripartum hysterectomy. Okay, then placenta accreta. Yes, you know the one of the remote complication of your LSCS is morbid adherent placenta. Okay, morbid adherent placenta. So usually we before OT we diagnose with ultrasound report. So placenta is in the lower uterine segment. There is no line of separation between the wall and the placenta. Such cases we suspect placenta, morbid adherent placenta. Such cases are for usually peripartum hysterectomy. Okay, all of you understood, I think. Any doubt? No doubt? Okay.